Assalamu alaikum. Hello everyone. I hope everyone's doing good. Have a good weekend. Here we come again for the CPDs. So welcome Uswa, Benish, Foster and myself Amna. so today's topic is tendinopathies, yeah?
Tendinopathy
And Foster
rehabilitation. Yeah.
Joseph is going to present the presentation inshallah, and she'll be guiding us throughout and welcome. I welcome you all, and Foster Joseph, go ahead. Good luck.
Stage is mine, huh?
Yeah.
Okay. Right. To begin with, to introduce myself, my name is Foster Joseph. I'm working as a senior physiotherapist in MSK settings in NHS, County Durham and Darlington NHS Foundation Trust. Today's
Proud of you,
topic
girl.
is, thank you. Today's
Good.
topic is about tendinopathies and their rehabilitation. So, we are not going to talk about tendinopathies itself, like that, we won't go into the details. Rather, we'll discuss more about how to rehab tendinopathies. I think everybody is familiar what a tendinopathy is, how it occurs, and what are the common tendinopathies. So, to open the question, what is your understanding of differences between a tendinitis, a tendinopathy, a tendinosis, and a tenosynovitis?
Oh, it's very difficult. It's
Can
always a
anybody of you give me an answer?
I can't.
Yes, please go ahead.
Okay, so talking about the tendinopathy is it's more like a chronic condition, not the very acute. When
Mm-hmm.
there is altered biomechanics of the tendon because of the long ongoing pains, now tendon has changed its biomechanical properties.
Yeah.
So that is tendinopathy. Tendonitis could be just the acute inflammation of the tendon, sometimes straight
Yeah.
away right after the injury.
Yeah.
Partial tendon tears or full tendon thickness tears is more like inflammatory changes when they are within the tendon. That is more like tendinitis.
Yeah.
And
Yeah.
what was the third one?
And
Tendinosis and
Tendon,
tenosynovitis.
tendinosis. No, I think I should just leave it on you
leave,
for a good
leave
placement.
Yeah, so tendinosis basically is the long-term physiological change. When a tendinopathy is like old, that it actually physically changes the appearance. So now the inflammation, that initial stage of inflammation has finished. Now the collagen fiber structure, the fibrous structure has changed. There's calcium deposition, and you know how a scar forms.
Yeah.
When a scar is formed, then it turns into. So you can say like tendinitis is more acute, then it goes on. If it continues, it becomes a tendinopathy, and then a tendinopathy turns into a tendinosis. A tenosynovitis, however, is more of an inflammation of a tendon sheath rather than tendon itself. When the
Yeah.
sheath around the tendon swells up, your common tenosynovitises are your deeper veins where your abductor pollicis longus and your extensor pollicis longus tendon sheaths become inflamed. I think your trigger finger is also triggered by tendon sheath. So these are more important of tenosynovitis.
Hey guys, I just have a patient yesterday, so I will be more interested in listening.
Good,
I think she's
good.
suffering from tenosynovitis then.
Deeper veins, yeah, deeper veins,
Yeah.
tenosynovitis. So I'm going to share my screen. Let me know when it is seeable.
Okay.
Right. So are you able to see
Yes.
Yes.
the PowerPoint? Right. So today we are going to talk about tendinopathies rehabilitations. Talking about, as we have discussed, what is a tendinitis versus tendinopathy, a tendinosis, and tenosynovitis. So, tendinitis is an inflammation of the symptom and results from micro tears that happen when the muscle tendon unit is actually overloaded with a tensile force that is too heavy or too sudden. So it is a force for which the tendon was not prepared, and it was a sudden strain that has either tore the muscle, given it a micro trauma or a macro trauma, and then in results it causes inflammation in the tendon. That's more of a tendinitis. Tendinosis is a degeneration of the tendon's collagen in response to chronic overuse. When overuse is continued without giving the tendon time to heal. So now it's a repetitive tendinitis. It's like injury, little bit healing, then re-injury, healing, and then there's continuous cycle of injury and re-injury and healing. Then it turns into more of a tendinosis.
If it's just sudden, like someone says that I have just picked up and I had a shooting sharp pain around my neck, like around C7 area, and then they are
Yeah,
now having swelling in the hands, and then this decurvines area,
that will be more of a muscle strain or a tendinitis.
Yes.
and they have a sharp shooting pain around the course of ulnar nerve as well.
That would be more of a nerve pathology rather than a tendon involvement.
Mm-hmm,
Yes.
mm-hmm, mm-hmm.
Okay. So, without giving the tendon time to heal and rest, such as with the repetitive strain, so it's a repetitive load with walking, hopping, jogging, running, any kind of repetitive strain will result eventually into tendinosis or tendinopathy. So, tendinosis results even with tiny movements such as clicking a mouse. So people who use have sedentary jobs using a mouse, etc., things like that. Any repetitive load will can lead to tendinosis. I've written separately about tendinopathy. So tendinopathy is used to signify the combination of tendon pain and impaired performance, often result often associated with swelling of the tendon and intertendinous changes. So Alfredson was the one I've taken this definition from Alfredson's study. He evaluated by ultrasound or MRI. Okay, so when it is seen in ultrasound and MRI, those physiological changes in tendon's structure that result in tendinopathy. The diagnosis of tendinopathy can, in contrast to tendinitis and tendinosis, be made clinically without histopathological examination, right? So, uh, diagnosing a tendinopathy is easier compared to a tendinitis because for tendinitis and for tendinosis, you would have to some kind of imaging, like you would need ultrasound or other MRI to confirm the changes or confirm the inflammation around the tendon. But tendinopathy, you can diagnose even with your tests like resisting the tendon against its function, and then you would know that it's rather more of a tendinopathy. It is recommended that term tendinopathy be used as a clinical diagnosis for patients with pain in the tendons. Tendinosis and tendinitis require a biopsy. So it's just again the difference that tendinosis and tendinitis would either require a biopsy showing degeneration or inflammation. Its symptoms are present for more than 3 months. Then now it is defining the course of time, which one is called acute, which is subacute, and which is chronic. So if symptoms are more than 3 months, then the tendinopathy is more of a chronic nature. But if symptoms are between 6 to 12 weeks, it is more of a subacute, and of course, less than 0 to 6 weeks will be more of a acute stage. This is this is a global as standardized definition of chronic and acute tendinopathies. Any any questions still here?
No question.
Everything's all right?
Yes.
Right. So I've added the ultrasound image of how the tendon would look when you see them on the image. So, oh, sorry, tenosynovitis, as we have discussed, is a protective sheath, the synovial membrane. And when it gets inflamed due to overuse or any kind of injury or trauma that surrounds the tendon, it is more of a tenosynovitis. So, if you see the tendon, first seeing the picture of tenosynovitis, the tendon itself is not disturbed. It's the sheath around that's inflamed. So
Yes.
that's your the name synovitis, that the synovial membrane is inflamed.
Yes.
However, tendinitis, you can see there are micro traumas and the tendon is also swollen. So there's a little bit of inflammation, that acute stage of swelling and increased blood supply and all those kind of things, changes are going on.
Yes.
And hence and hence it gives you pain in response to that. However, your tendinosis or a tendinopathy, they both have the same. I mean, tendinosis would be a more chronic change. Here, your tendon is not inflamed, your sheath is not swollen, no inflammatory changes, but now Chronic changes have taken place where there is structural change, and you can see there's a scar tissue
Yes.
in the picture. Now, this is a very important point. Oxygen con
Sorry, excuse me, Foster, because you are
Mhm.
sharing screen, so you have the option of just zoom out. So you can just zoom out
How can I
so
do that?
that we can just see it little bit more clear.
Uh,
Just with your hand.
like
Yeah.
that?
Yeah. Very good.
Oh,
Thank
okay,
you.
okay, okay. Yeah, yeah,
So
no problem, no problem. It's just so we can't, you could see the full
yeah, that's okay.
picture of.
You can it's manageable with you, so you can handle it by moving right or left. That's okay.
Oh, yeah, 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 that's fine, that's fine.
Okay.
Um, right. So when we're talking about oxygen consumption of tendons, it is 7.5 times more lower than a skeletal muscle itself. So when we're talking about a muscle belly, compared to that, the blood supply of a ligament and a tendon is 7.5 times lower. Hence, the healing would be lower as well.
Agree.
So because of the low metabolic rate, and well, but actually why? So nature hasn't just given you something without any reason. There is a reason for it having a low metabolic rate and low blood supply, because it also saves it from injury. Because there is less blood supply, there is less metabolic rate, there is less susceptibility to be more sensitive to strains, so they are stronger in return. But when it comes to when they are damaged and when it comes to healing, that's also slower as well. That's the caveat of having less blood supply. So the low metabolic rate and well developed anaerobic energy generation capacity are necessary to carry loads and maintain tension for long periods. That's why we have less supply, reducing the risk of ischemia and necrosis, and hence the injury. But consequently, low metabolic rate will result in slow healing. So this was taken from a study by Lawrence et al. I've also added as you can see, I've also added the
References.
references to the studies
Yes.
from which I have taken all my definitions. The first one was taken from Bus et al. I should mention there, so give them the acknowledgement. Right. So the most common tendinopathies that you see, Achilles on top, I would say the most common tendinopathy so far. Then patellar tendinopathies, lateral elbow, your golfer's elbow that you call little epicondylitis, medial epicondylitis, your golfer and your tennis elbows, rotator cuff tendinopathies, tib post tendinopathy. I myself have got tib post tendinopathy as well.
Mm.
So these are one of your most common tendinopathies. It's very important to make the differential diagnosis when you're talking about Achilles. So make sure it's posterior impingement. There is no bursitis, no referred pain. When we're talking about patellar tendinopathy, then make sure it's not an anterior knee pain, not a patellofemoral pain. Lateral elbow, referred pain from cervical spine could be. It could be a referred pain from cervical, it could be a referred pain from your shoulder, it could be a nerve entrapment in elbow. So
Yep.
whenever you're making a diagnosis of tendinopathy, make sure you rule out other joint causes or other nerve causes. Rotator cuff, it's important to rule out any acromioclavicular joint issues, any
Yep.
kind of bony issues, any instabilities, glenolabral tears, glenoid cavity labral tears, etc. And tibialis posterior, it's important to rule out flexor hallucis longus. And when you have flexor hallucis longus, you will tend to be more tender on the tunnel, on the ankle tunnel. However, if it's a tib post, you'll be more the palpation would be more sensitive on the navicular bone where there's the insertion of your tib post. So these are the keys to correct diagnosis. When we're talking about Achilles, so careful, as I discussed, I always discuss palpation is the one of the most important key factor of diagnosing when we're talking about when we are distinguishing and ruling out other joint and nerve causes. So as I said, the primary source of area will always be tender. So it gives you a hint, okay, that could be the source of area. Now it depends on your knowledge of anatomy, how much you know, where is the insertion of which particular tendon. So you will be able to rule out, I think it's this rather than the other tendon. So careful palpation, And obviously, when you stretch the muscle against their action, and if they feel instant pain in that tendon, then that's more of a diagnosis of that particular tendinopathy. So careful palpation, careful examination. When we're talking about, sorry, I'll just zoom it out so we are not confused. So careful palpation, passive plantar flexion test for posterior impingement. That would be for your Achilles. Then when it comes to patellar palpation, and you can also stretch the tendon, and that will give you pain. When we're talking about lateral elbow, careful examination of cervical spine as well, awareness of forearm nerve entrapment. So cubital tunnel syndrome, where your ulnar nerve is trapped, is very common site of pain on lateral elbow as well, common cause of pain. Rotator cuffs, examination of AC joint as discussed, any instability, any labral tests. And when we're talking about tib post, so flexor hallucis longus, as I've already explained, it's more in the ternal, which is on your malleolus. However, on tib post, tendinopathy is generally more at navicular insertion. So that was more about of a little bit explanation of tendinopathies and little bit of differential diagnosis. I'm not indulging more into differential diagnosis because when we are going to talk about individual tendinopathies in detail, we'll talk about their diagnosis, how to rule in and how to rule out. Today is all about the general rules, general principles of rehabilitation of tendinopathies. So main principles. When we're talking about rehabilitation, so our main goal is from pain to progression. So how are we moving from pain symptoms to progressing? Improve muscle and tendon capacity to manage load. So our main goal is that we want our tendon to be able to be able to manage the loads that are posed on it. So our first goal would be to reduce pain, right? But it's very important the compliance of patient. Then effective load strategy and what exercise you select is important. Moving towards key goals. So these are the important points that you would have to keep in mind whenever a physiotherapist is designing an exercise protocol for their patient. To improve the capacity of the tendon and muscle and to manage the key goal would be to improve the capacity of the tendon and muscle to manage the load. As I've already said, your muscle and your tendon should be able to manage the load that it is being exposed to. Include patient counseling, very very important. So what if there are loss to follow-ups? What if your patient is not coming, they just take 1 or 2 sessions and then they just not motivated enough? So it's very important to counsel them. And patient education, that so you give them a proper framework, just put it in front of them that that's the time you're expecting. These are the theories that I'm basing all my exercise plan. This is the evidence there. Do counsel them, let them know what they're so you stand on a realistic ground. There are realistic expectations rather than they expecting you to just use a magic wand and take it away in quick fix. That's not possible. So it's very important to you, so for you to counsel your patients. How are you going to counsel? Now that's the question. Use evidence-based physiotherapy intervention as a base of counseling, right? Which I will discuss later in this topic. Educate about normal healing times. Very important. How long it's going to take. Role of the mechanical loading. Why we are loading the tendon. Why we are making you go through all that pain. What's the reason? Modifiable risk factors. So we are not just going to concentrate all on two exercises. We have to see what other risk factors we can modify. For example, patient's weight. If they can manage their BMI, that's going to help a lot in rehab because it will reduce the intrinsic forces on the tendon itself.
This is the
Important.
most hate about it. They don't want to work on it.
Yeah, yeah. So managing weight is not an easy task though anyway. Shoe wears, important shoe wear, especially Achilles, lower, especially when it comes to lower limb tendinopathies, an important shoe wear, very important point. For example, if your patient is flat feet, I had this case. I have a patient of complete tear conservative manage of Achilles tendinopathy. I'm with him on the return to sports phase now. But what I noticed that he was very flat feet. And what happened when he was loading, he ended up developing tendinopathy in his other Achilles, the good leg Achilles, right? So as soon as replaced with some insoles, that has corrected the biomechanics. So very important factor. Then time of recovery. Each component in rehab program, particularly loading, must be manipulated in relation. Now we know that when we discuss our goals with the patient, what their goals are. If a goal is just to return to normal activity, then that's fine. Then loading, strength training after a particular time, they will be all right then returning to their normal activities. But if the goal is to return to running, football, high impact training, then you would have to devise your plan according to their needs and and you have to simulate their work environment and add sports specific regimen as well. Okay. So what you can do then depends on whatever their needs of their sports are. You can manipulate different factors. So there are various factors, for example. So you can manipulate the load. So load will be constant. You're going to work on your load, but then you're going to add more components. For example, speed, ballistic loading, fast loading, slow loading, and then changing the nature and magnitude of forces, how they will be affected, at what speed, at what rate they will be applied to your tendon, to a bone. So we always talk about bone, muscle, tendon unit. They work as one unit in order to achieve the full goal. So it will be more clear when we'll discuss the exercise plans in the next coming slides. Talking about, so I'm going to discuss about phase one, phase two, phase three. Phase one. Phase one will be more of a pain management. Can someone tell me why pain management is important?
Because then they will be able to proceed with the other
Exercise.
you
Mm. Yeah.
know,
Yes.
treatment plan.
Plus, pain management is important in the engagement of your muscles as well. If it is painful, naturally your brain will shut down the chain. Your
Yes.
motor response, pain inhibition. Do you know about pain inhibition mechanism? So when there is pain in the body, you know there is a natural response of muscle guarding. The
Agree.
muscles will go, the muscles will go slow down, they won't do their function properly.
Yes.
This overloads the other muscles that are working okay, and then it creates like a vicious cycle. So it's very important to control the primary reason, primary cause of pain to correct the full mechanics. Otherwise, it's going to discuss. We can't just straight away jump to loading exercises. We have to work through phases. So the
Yeah.
phase one will be more concentrated on uh, pain. Pain can affect muscle efficacy to engage in functional performance, as we all know. There was a study by Henrinsker et al. They found that pain in tendon causes reduced motor responses with functional effects on the ground reaction forces. So can you see how it is affecting the whole? It's affecting the whole chain. The muscle responses when you are walking, when you're doing your functional activities. So what's the effect? There is no efficient muscle engagement. There is no proper response from the chain uh, coming from the ground reaction forces. So, and this was just pain in the Achilles tendon. I forgot to mention Achilles in it. They studied on Achilles tendon pain. So, pain will be more prominent in reactive tendinopathy. So, sometimes we can just have like a simple general tendinopathy, but sometimes it could be more painful because some people are more reactive. The inflammatory process is more uh, uh, posed, more prominent in those patients. So, in this condition, the tendinopathy is going to be a bit more painful, which is called reactive tendinopathy, because they're just going to react very fast to the load, and the next day they will be like, oh my god, I walked about 30 minutes a day, and next day I was in so much pain. That would be more because the tendon is reacting. So key to reduce pain is load management. So in the first phase, you'll be just managing the load. You're managing pain with painkillers. You're managing load. You're managing load in a way that you're avoiding those activities that gave him the injury on the first place. So avoiding those activities like walking, jogging, running, any kind of thing that gave the. So I'm going to discuss in detail what those activities are. Avoid activities that place a compressive load on the tendon. Usually, this is any activity that would involve stretching the affected muscle or direct tendon compression. So when you stretch, you're increasing the tensile forces on the tendon. That will disturb it and cause further strain and injury. Or direct tendon compression. That would be when you're trying to create too much force into the muscle, that will create more compressive forces on the tendon, because tendon is the one that, so your tendon is your bridge of your muscle belly to your bone. So what does tendon do? It transfers all those forces through the bone, and then it is transferred all the way down to the ground. But that bridge will be overloaded when you're producing too much. When, for example, you have given a person to just hold a 10 kg dumbbell, it's going to produce too much force in the muscle belly of biceps, but at the end that's going to load your tendon. So that's too much compression load on your tendon. Does that make sense?
Yes.
Yeah. So any kind of increased tensile load or compression load we have to avoid in the very first stage. Cut out activities that involve stretch shortening cycle. Does anyone know about that?
Yes, but yeah, I do have the understanding of that when we talk about the rehab program for, or how to um, work on the load management strategies for tendon rehabilitation. Ultimate important thing is to focus on the stretch shortening cycle of the tendon.
Yeah, that is in simple words, you can say it's more of a reflex, stretch reflex.
Yes,
For example, when a person who is playing golf, he has to stretch his hand a lot more back in order to give the final strike, you know. So in order to, before you contract, you stretch your muscle. Same as when you're kicking a ball.
agree.
Yeah. So a stretch followed by a shortening cycle. So your muscle stretches and then it concentrically shortens. So this is what called stretch shortening cycle, SSC in short. So cut out these kind of activities. Plyometrics also come, very important example. Plyometrics come in your stretch shortening cycles, but this is more based on like we talk about the stretch reflex. So any kind of sudden jerk and followed by shortening of your muscle.
Okay.
So cut out the activities that involve the stretch shortening cycle, which occurs when the tendon has to behave like a spring. Do you
Hmm.
understand what I mean? So you stretch it and then you let it go. So you
Yes,
stretch the spring and then there's a recoil.
agree.
Okay. So stretching, then shortening to store and then release energy. So when you stretch it, you store the energy and then sort of you release it. So it's just like a spring. I
Yep.
think that now makes a bit more sense.
Yes.
So what was the important? So in first phase, load management is important. Avoiding the activities that are causing pain, for example, compressive and tensile forces, and cutting out the stretch shortening cycle, any kind of activities which are spring like or the stretch reflexes activities. And pain management, so using ibuprofen medication. The last point I've mentioned, anti-inflammatory medications such as ibuprofen can be used to reduce the reactive response. Use painkillers. Icing is very important. Use icing to control the swelling.
Yes.
Coming back to the second point in this slide, isometric now. So in terms of the exercises, the best one so far, evidence-based exercises in the very initial phase are your isometric exercises. So I'm going to hide. Can someone tell me why is that? Why isometric?
Because when again we are saying that mm, pain management strategy is to avoid or to manage compressive and tensile loading. So still we
Yes,
are following the same pattern. We are not changing the length of the tendon or the muscle, but still we are trying to
exactly.
load it in an ideal way to build up
Yes.
enough strength, but slowly and gradually.
And that would be which range? Which range would be the more suitable range to work?
Mid
So you
range,
know we have outer, inner, and middle range.
middle range.
Middle range would be the safest range to work.
Agree.
Okay. If
Yes.
you are contracting too much, if you're contracting too much, then it's too much stretch on the muscle, too much compression on the muscle. And if you're stretching too much, that's too much tensile on the tensile loading on the tendon. So the safest range would be the middle range.
Yes.
Okay. So isometric exercises can help to reduce pain. These exercises should be done in a position where there is no tendon compression, like I've already discussed, usually in the mid range of the muscle. They can be repeated several times a day. So normally the gold standard are used as 40 to say 60-second hold. It doesn't have to be, you can, we always say it's always an individualized plan. If a patient can hold 15 to 30 seconds, start with that hold, progress to 30-second hold, then 60-second hold. So, but this is like I'm giving most of the measurements that I've given are gold standard and like the average measurements that are used most widely. So 40 to 60-second holds, 4 to 5 time repetitions to reduce pain and maintain some muscle capacity and tendon load. In highly irritable tendons, so when patients have like too much high SIMs, too much severity, irritability factors, a bilateral exercise can be used. So you can support with your good leg as well, with your good hand. Shorter holding time, so just don't do it 30 seconds, do it 20 seconds, and fewer repetitions per day may be indicated. So, like I said, you can always adjust your plan. So that was your phase one.
Yep.
Make sense?
Yes.
Now I'm going back to a table that I have added. So there was a study by Goom et al. I've just completely copy pasted this from Physiopedia. They have, so I thought if I discuss that, then it will make more sense. So this is like a general summary of your rehab protocol. The first phase is about reducing the pain. So isometrics in the mid range. Um, is everything okay?
Um, yes.
I just heard someone's call going to reconnect it. Right. So isometrics first in the middle range, as we have discussed. The second will be improving the strength. So now we'll start reducing the gradual load. Okay. So
Yes.
heavy, slow resistance training, non-compressive position. We'll talk. I thought I'll show you in the end when we've discussed. Then this will all make more sense. These tables will make more sense when we'll discuss about it. But in summary, when we talk improve strength, there are different strategies that are used. Heavy, slow resistance training used. Then eccentric training is used. Concentric training is used. Isotonic strengthening. Different strategies are used. I'll discuss them all in details. Then functional, very important because the end goal is to return to functions, right?
Yep.
So you have to build the functional. We are not just going to strengthen it and just leave it. Go to strength training then. Progressed strength work, functional training, sorry. So progress strength work into more functional tasks. Create, for example, if the function is throwing, then you're going to create exercises where more throwing muscles are used, right? Activate that kinetic chain where he's going to need more support. Then increase power, work on speed, add speed. Develop stretch shortening cycle, start adding the plyometrics,
Yep.
plus minus graded return to running, right? Then graded return to activity. And then, of course, more sports specific like add drills, sudden cues, sudden changes, sudden agility training. Lots and lots of variables are added. There was another study by, sorry guys, this is really, really, really small for some reason. This was a protocol by Marilis et al. It's different wording, but the concept is the same. So the first is isometric loading. Isometric loading is about more than minimal pain during isometric exercise. Pretty much the same. This is different. In different people have uses different protocols, so they have given different repetitions. So 5 repetitions of 45 seconds, 2 to 3 times per day. Progress to 70% of maximal contraction. This is all different strategies, but you all always tailor your exercise program according to your needs. Then comes the isotonic when you start adding concentric loading, then energy storing loading, and then, of course, return to sports. So we'll discuss this all in detail. This is just a little summary. So isotonic, where your length of your muscle changes, and then more energy storing exercises. Can anyone give me an example of energy storing exercise?
Mm,
So your plyometrics,
yep.
jumping,
Yes.
hopping, skipping,
Exactly.
because
Again, focusing on the stretch shortening cycle now.
exactly. And then comes your, in the end, here comes your return to sport. So low tolerance to energy storage exercises, progression that replicate the demand of training. So same, pretty much a mix of same. Now you're just going to make more functional. Does that make sense?
Yes.
Everybody ready to move in detail to the phase two, which is the more complex one.
Ye-
Any questions so far?
No question.
If you want me to repeat anything, if you want me to, so I can summarize it again. Phase one was all about load management, managing the pain with medication, ibuprofen, gel, whichever. avoiding aggravating factors. So the tensile, the stretching, the compression, the uh, load producing, the
Yes.
strength producing, the more, don't expose it to more load.
Yes.
Okay. And avoiding stretch shortening cycles. Make sense so far?
Yes.
Is everyone there? बाकी सब लगता है सो गए. आमना उसवा
Yes, we are here.
तो वीडियो तो शेयर करो ना.
एक्चुअली मेरा तो चार्जिंग पे लगा हुआ है फोन.
अच्छा वो फिर ऑडियंस का जवाब नहीं आता तो मुझे लगता है मैं खुद ही से बातें कर रही हूँ.
No, you are presenting very good.
आमना किधर है?
Appreciable.
I'm not
Uh,
getting ready.
आमना बर्गर खा रही है. आमना गायब हुई है. ओके. ये वाला हिस्सा काट दी कैंडी. ठीक है.
It's hard to cut in between, so don't worry. It's fine. It's fine. It's just
No,
that's okay.
don't add that.
Yeah,
Just crop it and
you
crop
know,
and then
after
combine.
every 30 minutes, there should be just a little gap of just taking deep breathing, so readers and listeners can
This is
enjoy that.
very informal, guys.
That's okay.
Okay, right, coming back. So coming back to our phase 2,
Yes.
this is all about, guys, I'm just giving a disclaimer. I've taken a lot of it from Physiopedia, which was really, really, really good and very, very evidence-based. And I've opened their articles as well. And in the end, I've added all the references of the studies. So if someone want to read those articles, I don't know why this slide is not full, the last one. But when I send these slides, well, I add the link to these slides in the YouTube channel. You can see all of the references are there.
Great.
Okay. Right. Coming back to now phase 2, which is about improving your tendon strength. So now we're working on gradual incrementation of, we're going to increment gradual load. Important points. Strength is so what is strength? Strength is now the ability to produce force and manage load. So now your tendon is not just going to produce its force. So what happens? It's going to produce its force in the muscle belly. So as strong as you're doing the contraction, more muscle fiber recruitment is coming, more force is produced. But at the end, all that force is eventually going into the tendon. And if that tendon is not strong enough, it's gonna strike away, it's just gonna collapse. That tendon needs to know how to manage the load.
Yes.
And this is the training you are going to give to your tendon, right? So what happens? People say, I do a lot of exercise. I go to walking, I do that. But walking is the end state. This is a functional thing. Your tendon, walking is more of a, I'll discuss about this in detail. But walking is a functional thing. A functional exercise is not a particularly targeted exercise of a tendon. That in order for your tendon to go really stronger, you would have to individually target that particular tendon in a particular angle to a particular load that will then cause the injury of the fibers and then healing of the fiber and the physiological adaptation of the tendon, that it will become so strong that any kind of unpredictable exposure of force, unpredictable sudden jerk or jump, it would be already stronger enough to manage that load. Does that make sense?
Yes. Agree.
Yeah, right. So, improving strength. How much strength is needed? That's the question. So in general, as a rule of thumb, gold standard, in general, we aim to achieve equal strength in both left and right side of your muscles. Okay, because if left is strong, right is going to compensate. If right is strong, left is going to compensate. That's going to cause muscle imbalances and injuries, further susceptibility to strain and blah 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 and all that vicious cycle. So we want equal strength in both sides, which can be measured using your repetition maximum. Does anyone knows the concept of repetition maximum?
Yes.
Yeah. So 10 repetition maximum means a load, a load which is enough for a patient that they can only do a maximum of 10 repetitions. They can't do more than that,
Agree.
right? So that would be your 10 repetition maximum. So basically 10 repetitions of an exercise is used. Some people use 15 repetitions, sometimes 8 repetition, depends how much load you use as a progression. Okay, so gold standard wise, starting 10 repetition maximum. Tendinopathy loading programs generally fit within three categories. So I'm going to read a paragraph here. When we're talking about strength, so in general, we aim to achieve equal strength of left and right, which is 10 repetition maximum. Research has focused on tendinopathy loading program that generally fit within three categories. So the first one is eccentric loading. The second one is heavy slow resistance, which is also called your HSR training. And then when you combine little bits of both, that is your combined training. You add a bit of concentric work, you add a bit of plyometrics, you add a bit of load energy trainings, your combined training. So in the first, we used to know there was only eccentric. I know so far when we used to study, the most acceptable gold standard was just the eccentric training. However, now the new research tells you that load training is very important. The more load you add, the more adaptability of your tendon. So a bit of a mix of all these three, your eccentric, your combined, and your heavy slow resistance is going to give you the best results to improve strength. So I'm going to discuss further about it. Lost my slide. Start load work in mid-range. So again, mid-range, the safest one, because your tendon is not ready to take excessive loading in any of the extreme, neither too much inner range or not too much outer range. So mid-range, the safest range. Avoid heavy loads in end of range to avoid compression on the tendon insertions. For so long, Alfredson's, does anyone knows Alfredson's protocol? So Alfredson's protocol for eccentric exercises, commonly that you use for your Achilles tendinopathy, standing on the stair top, slow exercises, slow dorsiflexion down, slow
Great.
plantar flexion, heel raises,
Mm.
your eccentric protocol.
Great.
Yeah. Then
And
you
going
first start
up.
with your double.
Yes,
Yeah, go on.
you start with double limb supported. So when you are going up, so more like just slow standing, but very slow. So literature says slow means at least taking a 5 to 8 second time when going up, and holding there for at least minimum 25 to 30 second. It again depends on the individual bearings, and slowly going down again means 5 to 8 seconds time, and then you can
Yeah.
just stand on your good side and target on your treatment leg, and now you are more like doing push down through the heel, and again taking time very slow till the end range and hold it and slowly coming back to the resting. So this is repetition 1.
Yeah. So basically, eccentric is what? When your muscle is creating force, but it's more in a lengthened position.
Agree.
It's not actively contracting. That is your eccentric control. So squats are a really good exercises. Control heel raises are a very good exercise. These are all your eccentric loaded exercises. Okay.
Yes.
But more recent evidence, come to the line 3, more recent evidence suggests the importance of including concentric and high resistance slow resistance training, heavy slow resistance training into the regimen. So if you start adding now with heavy slow resistance training as well. Eccentric work. So what is eccentric work? Where your muscle is lengthened. Eccentric work is more about high frequency. So they commonly use about 3 sets, 15 repetitions of any two exercises of you choosing according to which muscle it is. But your HSR is low frequency because it's high load. So low frequency, 2 to 3 repetitions per week, right? But gradual increase of a load. So more and more. So that would be against load. So like your leg presses, your hack squats with against the load, that will be more in the gym kind of resistance training work, like a HIT exercise programs, like against your resistance when you're working against the load
So
other
that
than your own
means
body weight.
HSR training means more like building up power rather than strength,
Yes.
right?
No. So strength, power, power is when you introduce speed. That is power.
Oh,
When
yes.
you add ballistic work, that is
Yes.
power.
Yes. Yes.
Strength is against the load. When you're working against the load, that will strengthen your tendon.
Now you're right. Yes,
Okay?
I'm just
Yeah.
missing two things. Okay.
No, no, that I know power and strength because we commonly use power as a strength, so it's very misleading. But in when we are talking about physiotherapy, power is more about speed. When you add ballistic component, speed
Actually,
component, that works on the power. Okay?
yes.
So HSR, right? So long time we have used Alfredson protocol as a gold standard. Now the concept is changing. More evidence is adding more of a heavy load resistance training and more of eccentric work added with concentric isotonic exercises. So I'm going to discuss these three very important. So we have compared all of them in a table now. So there were very famous three studies, very good studies with amazing results. Alfredson protocol is very famous for eccentric one. So if you see the first one, it just gives you a bit of a summary. So this is all about loading. This is the second phase training. Alfredson protocol, they used 3 sets and 15 repetitions. Initially, just using their own body weight as a load. So just body weight was a load, and then increase as pain allows, slowly adding more load. So using a backpack on a body, adding a bit more extra load other than the body weight, but more in eccentric, muscle lengthened position. Okay.
Yes.
Frequency was twice daily. As I said, eccentric are more high in frequency. Okay. So that was twice daily for 12 weeks of rehab. So exercises were heel drops, which are also called like heel raises, but you're dropping your heel a bit more down to stretch your Achilles tendon at the end range. Heel drop exercises. So when you do straight knee, that will be more of your gastrocnemius, and when it's slightly flexed, it's more of your soleus
Agree.
involvement. So
Yep.
Alfredson is more famous for your Achilles tendinopathy. Um, they use it on the Achilles, and that was very successful in treating that. The second one, I can't read the name. It's Nagel something at all. 2007, they used a combined strategy.
Mm.
Their sets were various. There was not like a fixed protocol that they're going to use 3 sets or 15 reps. They were various. If you read the study in detail, I've added the link. I've added the reference if you want to read it in detail. They used the body weight initially, but that increased the load in phases. I will talk about it in detail. If you want me to tell now how they used it, I can read that. So yeah, so they use the combined approach because they combine different exercises. They use rehabilitation phases and progressed patient depending on their symptoms. They also encouraged a monitored return, sports specific, which was. So they used one repetition maximum as well at the end. At the end, they used one repetition maximum. So that was 100% that patient can only do just one repetition. So
Mm.
instead, they start with the resistance of the body weight. So how they started with calves raises with body weight and progressed to in a similar manner to Alfredson's. They've added a little bit of element of Alfredson's using a backpack. So they added extra load, backpack, like heavy wearing a bag. So you're adding extra load, weight machines or adding weight on your calves, extra weight, Velcro weights, strap weights on your calves, weight machines to increase load. There are, however, several key differences. So, Silber et al., they included both concentric and eccentric, not just only concentric and eccentric exercises to include power and plyometrics. That is like the next stage. But just to give you a bit of a detail, so they have added eccentric plus concentric into their work. Their frequency was also daily, but for 12 weeks to 6 months. So as you can see, their time was a little bit longer than that. So 4 to 6 months in short. So what did they do? Comprehensive program, including eccentric, concentric, balance, plyometric exercises, and return to sports. This is what their routine was. Another study by Kongsgaard et al. In 2009, they used heavy slow resistance. What they did was they used 15. So they started with 15 repetition maximum and gradually increased the load until they could only do 6 repetition maximum. Progress at specific time points over 12 weeks. So that was also spread around 12 weeks, 3 times per week for 12 weeks. And that's their exercise protocol. Bilateral squats like presses, hack squat. Hack squat is where you have weight on your shoulders and you do squat, weight on your shoulders. and gradual progression in load, then gradually increased and added more elements, concentric, eccentric, blah, 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 all that. Okay,
Yes.
so we are still at our second stage. What we have studied so far. So the main important points are three protocols: eccentric, combined, and heavy slow resistance. That's how you start training your. Some people start with 10 repetition maximum. As you can see in different protocols, they've started from 15 to 15 repetition maximum to 8. Some used 12 repetitions, like Alfred used 15 repetitions. Um, Kongsgaard also used 15 to 6. And they haven't mentioned about Silber Nagel. Right. It's just 15 to 20 minute more session and then we'll be done. This is the most longest phase. There's another study, Meliaris et al., that combined eccentric, so eccentric, combined, and HSR. They used all three loading, and they found that three of them combined has the highest evidence for improving neuromuscular function. So not just your local training of your tendon, but your brain is also adapting when you use all three strategies. The greater the strain, the greater the adaptability in the tendon. That's the take home point. The greater load you expose it to, the greater it will adapt. But don't confuse yourself. Then why it injures when you expose it to a greater load? Because it wasn't ready for it. At that time when it was injured, the tendon wasn't ready for it. But now you have trained. It's same as you do bodybuilding. You prepare yourself for like many years, and now your tendon is ready. Now you expose it and it won't injure because it's ready, it's trained, it's stronger enough. Okay. Variables can be adapted. So different variables, now it's physiotherapist skills come in there, what the patient goals are. If their job, if their work is more if their sport is more speed, they're going to need more agility, like running. They're going to add the ballistic component, adding more speed component into it. So variables can be adapted for training, like under tension, like time under tension, how much the time exposure is, speed of contraction, position of the limbs, range of movement that's going to be covered. Rest is important. Rest between sets and scheduling the exercise sessions, for example. More load, more tendon adaptability, more speed, more power. Activities which involve shortening cycles, changing limb positions like squats with foot positions. So when you're working on the changing limb positions and you're preparing your body to that unpredictability of change position, so your tendon would be ready for multiple angles.
Agree.
No matter whichever angle you sort of expose it, it will be ready because it has been trained in all those angles, not just in one angle. But you have changed the position, you've added foot inversion and then you did squat. You added foot eversion and did squat.
Yes.
You added different positions. Okay. So in sports, so they are like useful, this kind of changes, change of directions and load is useful in sports with multiple directional loading. So now you're working multi-directional tensile loading and compression loading of your tendons.
Agree.
Makes sense so far? Any question? If you want me to repeat anything, just give me a right. For heavy slow resistance training, I want to add this point here, guys. When we talk about heavy slow resistance training, so some people have used gold standard for heavy slow resistance is used as 8 repetition maximum. So when you're progressing, use 80% of the force of load that they can use. So 8 repetition maximum is also used, which is like more commonly average time that's been used. You can start with 15 repetition maximum and you can progress to 8, but 8 is most average used. So 8 repetition maximum refers to the maximal weight you can lift in a good position or using a good technique 8 times. So that would be your 8 repetition maximum. Make sense so far?
Yes.
I'm going to add a little extra point into it as well. So according to ACSM guidelines, they recommend working at between 8 and 12 repetition maximum. So different guidelines, but depends which is more which is to your patient. Your patient might not be able to even do more than 6. So individualize, tailor your exercise program according to your patient. So ACSM recommend about 8 to 12. Gold standard are used 8 repetition. Congard, I can't say his name at all, on 2009, they use 15 to 6 repetition. So different studies have used different, depends on patient to patient and different populations. So ACSM also suggests 3 sets of 8 to 12 repetitions separated by 3 minutes of rest periods. Like I said, rest is important. Repeated 2 to 3 times per week. Make sense? I know it's too much information. You're gonna get confused, but when we summarize it, it will be all clear to you guys, hopefully. Happy so far?
Yep.
Right. So I've already discussed that when you combine all these three strategies, when you combine them all together, then it becomes the best approach of your tendon training.
Yep.
Right. The next slide, when we're talking about the rest time, guys. So make sure when you're prescribing. So for example, you're making an exercise plan just to make it a bit more easy and doable for you guys. If you're starting with eccentric exercises, which is fair enough, you can use that protocol. Start with eccentric, fair enough. Isometrics in the start, progress to eccentric loading. Give them 15 repetitions, add more frequency. If you want to add a bit of a combined, now start adding concentric loading, as we have discussed in this table, isotonic exercises. You can start adding isotonic, but then you would have to manipulate your repetitions as well. So use 8 repetitions, 3 to 4 set, 15 repetitions, 6 repetitions, whichever you want to use. Then you want to add a bit more variety. So you're using how heavy load. And as I've already said, for heavy load, your ACSM says 8 to 12 repetitions. Generally, guidelines says 8 repetitions. Okay so far?
Yep.
Right. Moving back to our point, which was about rest. Now, that's a very important point. Rest time. You have to think about your short term reaction of your tendon and the long term reaction of your tendon. Now, short term, net loss for collagen production is around 24 hours. So, at least give them a day off for your tendon to recover. You have given them the against loading work. They have done the exercises. They have done the exercises in a day. Now their tendon is going to need that 24-hour to recover the collagen that is it has used. So it's going to add more collagen because it knows that the compressive loading, the need of your tendon, the forces on the tendon have increased. So it has to heal it and rebuild it in order to get it stronger. So you're gonna need 24 hours for your tendon. So give it a rest time next day. Especially when we're talking about loading exercises. When you're only doing eccentric, you can do them daily, but you're adding more load, you have to give. That's why the cognal protocol was only 2 to 3 times per week because they needed that rest time within. Make sense? I hope मैंने खिचड़ी नहीं बनाई
No.
दिमाग में.
And
I
this is
will,
very important. Like rest time is important as well.
yeah. So when we're talking about the short term, so your tendon needs 24 hours to recover its collagen factor. But in long-term reaction, so it will be in getting injured, getting used, and getting recovered again. When we are saying getting injured, it doesn't necessarily mean that you're straining the tendon. You're actually just exposing it to that loads for which it has to now adapt itself and to get used that yes, I'm going to rebuild myself. So your body then heals, when you do any kind of training that breaks those muscle fibers. Power lifters do the same. When they do those heavy resistance training, the muscle fibers in their muscles break and then they remake. So in order, that's why even in gym they always say don't do the same muscle exercise every day. They have to give it a rest. So they do a leg day, they do a bicep day, they do a shoulder day because now they need rest. Does that make sense? So 24-hour time, 24-hour time for the rest. Now long-term reaction, it may take 3 to 4 months in response to loading programs. So what's the gold standard time? About 12 weeks, 3 to 4 months. So all studies at least support 3 months of rehab training. So there is no quick fix, guys. You can't just make your tendon strong in one day. The minimum time is about 12 weeks or 3 to 4 months. Okay, so that's the total time. So the 24 hours was your short term tendon reaction, and your long term tendon reaction is at least 3 to 4 months of training. Remember, gradual loading, very important. That's the key to our plan. And now we are done with our phase two. Any questions so far? The next is just functional. That's not more of a. Okay, guys.
Yes, no, so far it's good.
Yeah, I've added a little table that is, I think, pretty much the same what we have discussed. It just gives you different exercises. So, for example, for your Achilles, um, the isometric exercises would be these ones. Two legs calf raises, hold mid to end range. That's for the mid portion tendinopathy, and if it's insertional tendinopathy, then two leg calf raises, hold mid to end range. Pretty much the same. Patella's patella tendinopathy, two leg squats, decline squat, leg presses, hold mid range. As you've seen, isometrics will all be in mid range. For proximal hamstring, uh, then prone ham curl, of course, in mid range again. One leg bridge you can introduce, standing ham curls, pushing into a chair. So these are all isometric trainings, and then these are the strength exercises for your Achilles. First one is mid portion, second one is insertional, and your quads, squats, leg presses, leg extension, hack squats, and for your hamstrings. I'll read that. This looks a bit important. The first thing, tendinopathy rehab is complex and can be challenging. See a physio for professional advice specific to your case. First aim is to reduce pain. It's pretty much the repetition of same thing. To reducing aggravating movement that involves compression and excessive load on the tendon. This often includes rest from running, isometric exercises, and ibuprofen may be helpful. When pain settles, gradually increase load of the muscle and tendon to improve strength. Ideally, lift the maximum weight you can comfortably lift up to 8 to 12 repetitions. Same thing. 3 sets of 8 to 12 repetitions, 3 times per week, usually. Educate to improve strength. Make sense? When we're working against load, rest time is important. Functional rehabilitation. So, especially in return to sport like high impact. So, for example, if a person's goal is just to return to my normal day to day life, my like walking and stuff, then that would be easy. Once you have strengthened their tendon, they should be all right returning to gradual return because they're not going to put their tendon for that their tendon is ready. Like for simple bit walking, you have already strengthened with one maximum repetition maximum 8 repetition maximum. Their tendon is ready, strong enough. But when it comes to high impact activities like running, jogging, soccer, playing, and stuff like that, now they are going to need functional rehabilitation. Exercise specific to the functional requirements of the affected muscle and tendon. So we all know that exercise is going to be specific to their requirement of their sport. Improving the load capacity of the entire. Now come the concepts of kinetic chain. So you would have to keep in mind now it's not just the individual muscle, but the full chain, full kinetic chain. So you're going to add element where you're also working in the supporting muscles. For example, your knee support comes mainly from your glute control. When you're walking high hill, ascending order, your glutes take over. So if your glutes are weak, that's going to overload your knee. So the kinetic chain here involves strengthening of your glute muscle. That is also same for your calves as well. Involvement of glutes, involvement of quads. If your quads are weak, your calves compensate. So if you're no matter how much strengthening you have done for your Achilles tendinopathy, if your quads are weak, when you're going to return to functional, it's there is more likelihood of getting again the tendinopathy because your quads will be ending up to compensate. Sorry, your Achilles will be ending up to compensate for your weak quads. So now is important to involve the concept of the chain. Strengthen the full chain. Strengthen your quads. Strengthen your glutes to support your Achilles. Make sense?
Yes.
And addressing movement dysfunctions. movement patterning, false pain behaviors, false movement patterns. If there's a dysfunction, you have to correct that. If some muscle is weak, correct it because that's going to disturb the whole mechanics. In the whole chain, if one muscle is weak, that's going to disturb the full recruitment of the function. Because in function, not just your Achilles, when you're walking, you think it's only Achilles that's working? No, every muscle is working. The full chain is working. For example, even in your gait cycle, you have your heel contact, then flat feet, then your heel off, and then your toe off. So different phases. You're doing dorsiflexion, you're doing your knee bend, you're doing lots of things in one thing. You would have to train every element. So address the movement dysfunction for your tendinopathies. There's a little table. It just I don't need to actually read it, just tells you about different variables. So variables which are considered an exercise prescription thing, what happens during the function, range and direction of movement, what is the dominant muscle action, eccentric, concentric. Just identify which muscle is dominant in which movement and train that muscle. Build strength in muscle that may reduce load or affected tendon during function. Identify changes in joint range, tissue flexibility, movement. By tissue flexibility, they mean any kind of muscle shortening. If the muscle is shortened, work on that. Increase, and it's all about the same thing. For example, yeah, this is a good example. So when I'm talking about kinetic change and movement functions, look at that. Proximal hamstring tendinopathy, strengthening of gluteus maximus is important because it will reduce the load on hamstring.
Mm.
When it comes to um, your reduced ankle dorsiflexion range may lead to increased load on Achilles tendon. So work on if dorsiflexion is less, it's going to load your Achilles tendon. So that's how you correct your movement dysfunctions. So this is more of a broad based. Then you can use the same principles. You can use 15 repetitions. You can use 8 repetitions. You can add plyometrics. Plyometrics can come in, can still be there in function. For
Yeah,
example, hopping,
I get,
side hopping, side hopping, front hopping, single leg hopping.
yeah.
Last point. Keep in mind that you address the full kinetic chain. Adapt your exercise based on sports performance. Simulate the environment. Add more elements into it if they have to run. Add speed into it. For example, if we are talking about Achilles, so if a patient is a runner, then start adding speed elements. So sudden going up, slowly coming down. Acceleration, deceleration, because they have to jump. So their one leg has to accelerate, initiate that jump, and then the other has to decelerate. So practice it as an exercise. Jumping from one leg, landing on the other. Then switch, jumping from one leg, landing on the other.
Yeah, and sideways hops in front to back
Side to side.
and backwards.
Then agility, introduce cones, run zigzag to that cone. Introduce that sudden change, direction changes.
Yep.
But that is like the later stages. Address movement dysfunctions, as I've already discussed. Load, this is a very important point. Load is such a key area in development of tendinopathy. It is perhaps more likely that it is extrinsic factors such as, so extrinsic means something that's coming from outside, and intrinsic is something from inside. So extrinsic factors such as training volume and intensity that are more relevant rather than intrinsic factors such as biomechanics. How important? So even your doesn't matter about your own biomechanics. So even with your muscles and your joint biomechanics, that is important, agreeable. But when you manage the extrinsic factors, depends how much load. So if you give more load, that will work on more strength. If you give more repetition, that will work on more endurance of the muscle. So the research has shown that they are more um, relevant. They are more
Key
in
comp.
place when we talk about
Yeah.
the volume and the intensity. So the more you expose to the volume, the more you expose to the intensity, the more you strengthen your tendon. So it's not in the end just but about biomechanics. It's about manipulating those factors. Like many aspects of patient care, it comes down to assessing the individual and reasoning how each factor is linked and what is key. So now it's your own complex clinical reasoning. What is linked to what? In terms of movement dysfunction, look for differences between I think it's, I don't know, for some reason I can't see the full slide. Hang on a minute. So when we talk about load management, yeah. So it says, like many aspects of patient care, when it comes down to assessing individual reasoning, how each factor is linked and what is the key. In terms of movement dysfunction, look for differences between symptomatic and asymptomatic side. Yeah, not just the, don't only treat the symptomatic side, look at the asymptomatic, equality of both limbs, and see if they link with pathology. Also aim to restore enough range and control of movement for function. So now work on strength, range of motion, all those things. Now that is a question. Why, if they have to return to the sport, why they just don't straight away run to the sports? Why don't just return to the sports straight away?
Because
Like I've already discussed.
exactly,
Yeah, yeah,
we we have to rebuild the strength and enough bearings of the tendon to bear the loads.
exactly,
Yeah,
exactly. The first line is the answer. You need pre-built adequate strength.
agree,
When you're returning to the sport, that is not an exercise, that is an exposure.
100%.
You have to build that strength in your tendon in order to be exposed to that strength. So that's why we can't just straight away return. For example, I've given a nice big example here. Running is likely to have benefits on cardiovascular improvement, agree, fitness, cardiovascular fitness, but is less likely to be effective in building strength or improving tendon load capacity because it's an exposure, it's not a training. In addition, running activates the tendon stretch shortening cycle, which requires adequate muscle strength. So
Yeah,
if it doesn't have the pre-built strength, it's going to pop out, it's going to break.
agree.
So it requires that tendon has strength to avoid excessive load on the tendon because your tendon is not prepared for it, not ready for it, not strong enough for it. The difference between functional rehab and just doing your sport comes down to the type of loading and how the muscle and tendon respond to it. So your tendon was not ready, how to respond? It was a shock to it, so it will break because it wasn't strong enough. A graded return to sport is a valuable part of tendon rehab, but it isn't a replacement for appropriate strength work. Right? So graded return, like we have discussed, gradual return to sports.
Yeah, gradual and slow progression on the loads.
Identifying relevant movement dysfunction can be challenging, but should involve assessment of joint range of movement, tissue flexibility, control of movement, and biomechanics, as we have already discussed. Last point, return to sports. Increase, now it's pretty much the same what we have discussed. Increase in power is by reducing the repetitions, but increasing the speed of the muscle contraction will build power. Develop stretch shortening cycle by introducing plyometrics. So this is just now telling you what you have to do in order to gain what. Power के लिए add speed, stretch shortening cycle के लिए add plyometrics and graded return to running. Load tolerance to energy. So energy storing exercises. For example, when you have to jump, you have to store a lot of energy and then execute jump. Okay. So these kind of exercises add progression to replicate the demand placed on the tendon. Yeah. Again, when you'll practice a little bit graded jumping, then your muscle will be ready to those energy storing exercises. Add training drills, like training direction, like drills. Competition when patient is tolerant to full training. Yeah, then add competition kind of exercises. Last exercise, last thing, which is very, very, very important, and I think it's pretty much new thing. Now, local training तो आपने करा ली. Your tendon is fully trained, fully strong enough. It knows what to do. You have exposed it to strength. You have done something. What about your mind? How your brain is going to recognize that your tendon is strong enough? Have you thought about it? If your brain doesn't recognize that this part of my body is strong enough, how is it going to execute? How that channel of your brain to your tendon is going to work? That cycle.
Yeah, and patient education is preparing and counseling them that you are ready, and I'm confident that you will be fine for this exercise. So just slow progression on whatever I'm guiding you. I think just investing your time in educating them is the ultimate thing.
That is not going to work. That is psychological preparation. What about actual physiological preparation of your mind? So, this is a very important point. I really loved it when I read it. Tendon neuroplastic training.
Mm,
Physical training, you've done it. Yeah, your mind will recognize that your tendon is getting exposed. Yeah, there will be some little bit connection, but we need that communication. So there was a study by Rio et al. Now
mm,
we have two type of training: self-paced strength training and externally paced.
mm,
If the command is coming just from the inside of the body, if the person is just commanding itself, its body knows, its mind knows what it's going to do. It will do. But when the command is coming from the outside, from the environment, then your brain will adapt. When I read it, it will make more sense. So, self paced strength training, for example, a patient does 3 sets of 10 repetition contractions, lifting a weight without any external cue or advice on timing. This type of training may lead to recurrence of tendinopathy. When it's going to expose to unpredictable things, unpredictable environment, it can they can come with recurrence of tendinopathy, as it does not address the motor control sufficiently and does not change the corticospinal drive of the muscle. You
mm.
know those corticospinal pathways with our brain, those reflexes,
Yep.
right? So it is not, it is built in our local muscle, but it's not built in our motor pathways. Now, in order to build that, externally paced training would be when patient contract the muscle concentrically and eccentrically on auditory, like using metronomes, your headphones and stuff, auditory cues from outside. For example, 1, 2, 3, go. 1, 2, 3,
Yeah.
for inside, do that. Or visual cues. Externally paced strength training was shown to alter the tendon pain and cortical spinal control of the muscle. Does that make sense?
Yes.
So you have to now add the environmental cues, those
Mm.
sudden, unpredictable trainings that they have to do. So you're not just developing it as a local response when the person wants to do it, he wants to do it, but rather he's pre-prepared in his mind. So when it happens, it comes as a reflex rather than the muscle taking all the time to prepare.
100%. Yeah.
Okay,
Important.
does that make sense? Like you have a reflex, like garam jagah pe haath lagta hai, so you just do it
Yeah.
because your brain is trained, the neuroplasticity is there. But when you're training your tendon, you have to do it inside, so it becomes a reflex.
Okay. So that means not only into the environment where you are, just preparing them by, if I have patient with me and I am about to start, okay, we are about to do this exercise. So patient is already aware of that. Ultimately, he will do that and he will perform.
Yes,
So if I'm not,
pre-planned and sudden.
yes. So pre-planned, I will be pre-planned for him.
Yes, yeah, but he wouldn't know it.
Yeah,
Sudden perturbations.
quite
So
important.
that's the training you need to add.
That's so interesting.
Yes, because
That, that
it will
will work
need to
on my
become as a
patience.
reflex in your body.
That will work on my patients.
Yes. So you have to expose them to unprecedented trainings, add perturbations, add sudden changes, add music. जैसे आप pillow game खेलते हो, you don't know when the music is going to stop, so you suddenly stop the pillow,
Agree.
right? Add musics in the environment, add sudden commands in the environment, add external factors to drive that loading on the tendon. Does
Mhm.
that make sense?
That was so interesting. you, Foster.
Okay.
Believe me,
No
it's
problem.
just
So
a bit.
metronomes are like musics that mark a selected rate by time. So metronome is basically when like I said about the pillow game, when we use the music is playing and it suddenly stops, thing like that. So a metronome is basically a device that produces a regular repeated sound like a clock, help musicians
Hmm.
to play music at a particular speed. So then you can work in particular rhythm. You can work in unpredictable environments.
Mm,
You can work as a external command. If you
that's
want to,
yeah.
I can go back to that slide again. So hang on a minute. So repeat that. So now if we read that again, it will make more sense. So self-paced strength is, for example, a patient does 3 repetition contraction lifting a weight without any external cue, um, an advice on timing. So they don't have like a particular timing, or they don't. This type of training may lead to recurrence of tendinopathy as it does not address motor control sufficiently,
Mm,
right? But externally paced training would be when the patient contract the muscle concentrically and eccentrically. So working on a rhythm, even on a music, working on a rhythm,
mm.
and
Interesting.
auditory cues like using a metronome and visual cues. Externally paced strength training was shown to alter the tendon pain
Hmm.
and cortical spinal control of the muscle. इस पे मैं थोड़ा और डिटेल में भी पढ़ूंगी, तो मैंने भी सर्च करने की कोशिश की थी, but I want to search a bit more because interesting, and I think it's very very new evidence. It's a
Yeah,
very newly added thing.
exactly.
Yeah,
But
it was new to me as well.
yeah, thank you for
So that was all, guys.
it's the middle of the night. It's 12:23 a.m. and I'm enjoying your presentation. That means it's worthful to listen and to understand and to interact. Believe
Thank you,
me.
guys.
Yes.
Now load me with questions if you have any. I challenge you.
So we are still on recording if somebody wants to ask questions so that we can still keep it as the part of learning. Amna, we are seeing you.
It
You are
was
ready.
wonderful.
You are
It
ready
was
for
one.
questions now.
I have kept on running, doing things, and then I was like, but
Yeah.
I was listening.
But no,
So,
presentation was wonderful. Yes.
Very good. Very
so
good.
in order to define it easily, a self-paced will be controlled by the patient, and external paced will be controlled by the environment, someone else, not by the patient. They would just have to do it.
Great.
I thought I'll just make it
Yes.
easy.
So no questions, but what I have learned from the presentation is um, important phase is the pain management and then the load,
Yes.
like more like the strength load management
Yes.
strategy, which is in the strength phase. So I had a patient with gluteal tendinopathy, and he is now almost on his 3 months time.
Okay. Okay.
Uh,
Yeah.
so he was coming to me initially, like he had cortisone injection, so long history. He's not coming to see only physio for last 3 months, but he had diagnosed gluteal tendinopathy since 3 months.
Mm-hmm.
Initially, he had cortisone injection, and then he was advised to take a good rest of 2 weeks, and then seeing physio
Mm-hmm.
for good rehab protocol. So he was really.
Yeah.
So I was just following with the good protocol of pain management, and then starting with the isometric. So we were quite good. We were even on the good squats as well. But another day he came with, oh God, I don't know what I did. Like I'm really disappointed. I feel like I'm just back to my 0% recovery. So
Yeah. Yeah.
yeah, because he was confident enough. So he one day he just enjoyed some jogging and maybe more than 30 minutes of running, for which ideally
Yeah.
he was not ready. Even I gave him just a good sheet of, if you have to go stairs, what is the strategy, how to prevent,
Yeah. Yeah.
or
Yeah.
how to manage the aggravating factors if you have to jump or run or something like that. But now he's still again, so we almost unfortunately are back onto the pain management phase now. But no,
Exactly. Yeah.
since last 2 weeks he is improving well. But I
Good.
learned so many things that he was in my mind throughout the presentation, that how I had to just now go with that particular case.
Exactly. This was more like a general rule how you
Yeah.
progress.
Yes,
But of course, when you are talking about a specific tendinopathy, when we will talk about Achilles, we will see the whole plan of how Achilles goes. Then we will obviously use the same principle,
agree.
and then we'll talk about. That's why I didn't go much more into every muscle detail, because if I started doing that, there are so
No, no,
many
no, yeah,
tendinopathies. I
not
can't just tell in one.
generally.
So it was more of a general kind of tendinopathies management. But
Yeah,
using same principle, you can deal any kind of tendinopathy,
yeah,
whether it's Achilles, whether it's gluteus, whatever. Use the same principle. These are the most recent evidence-based standardized protocols of using rehab. But still, there is so much research that is still inconsistent in tendinopathies. Like they are tricky. Achilles tendinopathies are good recovered. Achilles and patellar are the most common tendinopathies in the world so far. Um, but the evidence is still needing, especially for the later stages, for the HSR. We still need more trainings. We
yes,
still need more research to make it as a complete evidence
yes.
for tendinopathies.
Hmm.
But yeah, that was all about the rehabilitation of tendinopathies. Any other question, any other thing you want to add into it? Any experience you
Uh,
guys had?
no, no questions, but yeah, as you have said that there is no requirement of any radiological findings like MRI or ultrasound in tendinopathy. I totally agree on that. But that was interesting for me to understand or to learn about. Okay, for tendinitis or what was the another one? Tendinosis.
Tendinosis, yeah.
So
Yeah.
we should prefer, just sending patient for the concerned specialist or somebody who can send them for MRI. That was interesting because usually for even Achilles, you just do Thompson test, and if it comes positive, just start with the basic management of immobilization, avoiding.
Yeah. But even with tendonitis, you can start early exercises. I mean, this tendinopathy protocol works with tendonitis as well. When you
Yeah,
basic load is always load management and strengthening, because if you won't treat it in the initial stage, ultimately it's going to convert into tendinopathy. So you can
agree.
start using the same exercise, same principles on a bit of a lighter note, but
Yep,
you can start doing them. It's just you don't specifically need to send them to an ultrasound, even to I mean to diagnose tendinitis or tendinosis. It's just to sort of confirm it.
information
It
of.
is only confirmed with ultrasound that yes, at what stage your tendon is. If it's either in a tendinitis stage, tendinopathy stage, or tendinosis, but you're just to diagnose it that yes, it's something seems something like this. You don't have to. You can just
Yeah,
start the protocol of exercises, yeah, and that will work as well. It's just like for tendinopathies, you don't necessarily need even to diagnose or to do that. But yeah, you can in order to differentiate the two, you're going to need some imaging to sort of
agree.
see at what
You better
stage
decide the
your tendon
exercise
is.
plan that how you will gonna just do the load management.
Sorry, say
Yes,
again.
I was just saying that yes, you are right. Just if we are, sending patient for some investigations, that is just for the sake of to confirmation on what is the stage of the tendon when we are planning a good rehab, protocol.
Yeah. And even to isolate, because obviously in rotator cuff you have four tendons.
Yes,
So your confirmatory tests is like when you do your MTK, it could be either. I mean, most of the tendinopathy is common in supraspinatus tendon, which is most common. But that doesn't mean it could be either your teres minor, it could be your subscapular. Any tendon could be involved. So in order to confirm exactly which tendon it is, ultrasound can help you make that decision. Uh, which tendon is involved.
correct.
Yeah.
Should I stop recording now? Thank you, Foster, for this very productive
Yeah.
and very very, I should say, informative CPD. I
Right.
believe me, I just have learned so many things, and I was interested on that because it's actually hard to treat.
Yeah.
You know,
I
it,
know.
it's actually
Yeah.
hard. Yeah, and
Yeah.
it's hard again another thing to counsel patient that it will
Ah,
take longer time. You must have patience. It's not
and
a matter of weeks.
especially uh, uh, the gym guys, the sports people, because they are very keen. They want to. They are worrying that they are going to lose their stamina with all that break. So they're like, I really want to return, but you have to see. This is what it is. There's no magic fix. You
Exactly.
have to go through that again. You have to start from square one. There is no like, oh, I'm just gonna return the next day. No, if you will do that, you'll probably end up injuring your other side as well. So it's very important to
Yes.
counsel them, prepare them psychologically. It is painful. It is physically painful for them and psychologically painful for physiotherapists. It's not hard to treat tendinopathies.
Yeah,
It's painful.
yes.
Yeah.
Thank you, Pastor, for that.
Any question from Uswa before we stop?
No, this was very good presentation, and it was very comprehensive. And although some of the part I have missed, but I will see your recording, and I will read the presentation detail. But it was very good, and you cover all the basic things and the complicated differential diagnosis. So overall, it was very good.
Thank you so much. I've sent the PowerPoint to you guys as well, so you can have a look.
Okay, yeah, sure.